Good afternoon, good morning, good evening, everyone, and welcome to everyone who's joined us today for this webinar, this series, the latest in the series, COVID-19 and HIV, latest updates and guidance. My name is Dr. Lucy Stackpore-Moore, and I am the Director of HIV Programs and Advocacy with the International AIDS Society based in Geneva, Switzerland. And we're thrilled to have a fantastic session for you today, and I'll introduce our panelists in just a moment. Our aim for this webinar today, and also as the latest one in the series, is to provide an opportunity for discussion on the COVID-19 pandemic and as it relates to HIV, and to present the latest guidelines and have a deeper look at the impacts noted in relation to testing and treatment gaps averted due to creative approaches to ensuring supplies, effective outreach, and the latest dispensing practices to prevent disruptions to HIV services during the COVID-19 pandemic. Just before we get started, we have a couple of housekeeping rules for today. Please note that given the number of participants here, everyone is muted, but feel free to send your questions through at any time in the Q&A, the question and answer box that you see at the bottom of your screen. Speakers will also be able to respond to that in writing, or also at the end of the session, we'll have a few minutes for a discussion and some verbal responses to the questions as well. You'll notice that there is a thumbs up symbol. If someone asks a question that you also have the same question, there's no need to write it again, just simply thumbs up someone else's question, and that gives us also a sense of the priority of responding to that question in the limited time available today. Please note that if you do have any issues with Zoom, you can find some additional guidance in the chat box, or also send any technical questions there in that chat box as well. Please do keep your questions focused on the theme of today's session, which is COVID-19 and HIV, the latest updates and guidance. And if you have any other questions on this topic, please do look at the IS website. We have a portal on COVID-19 and HIV that is kept up to date regularly, and also links through to the latest information available from key other organisations. You can also send questions as well as suggestions for future webinar topics by email to the address is coronaquestions@iasociety.org. So without further ado, I'd really like to welcome today's speakers and thank them for making time to join us today. It's a fantastic panel, and especially at the end of a long year and when everyone is extremely busy at this time. So an extra special thanks from all of us for all of the panelists for making time to share their insights and reflections today. Our first session is a joint presentation from Dr. Meg Doherty and Dr. Rachel Bagley from the World Health Organization, and they're going to be speaking specifically on the latest guidelines from WHO on COVID-19 and HIV testing. Dr. Meg Doherty is the Director of the Department of Global HIV, Hepatitis and Sexually Transmitted Infections Programs, HHS, at the WHO. Prior to her appointment in February 2020 to this role, Dr. Doherty was the Coordinator of Treatment and Care in the Department of HIV at WHO in Geneva since 2012. She has spent more than 25 years working in HIV and infectious diseases, including leading WHO's normative and programmatic work, focusing on expanding HIV treatment to all and reducing inequalities and access to the most effective antiretroviral drugs for people living with HIV. She brings many years of diverse country experience to her current role, having spent 10 years living in and working in low and middle income countries, advising ministries of health and international partners on implementing comprehensive HIV and infectious disease programs. Joining her in the second half of the presentation today is Dr. Rachel Bagley, who is the team lead for testing, preventions and populations in the global HIV, hepatitis and STI programs at WHO. This work includes supporting global normative guidelines on guidance on testing, including HIV self-testing and partner testing services, and considering how these can be implemented strategically, safely and acceptably for populations. So thank you very much for joining us today, Rachel and Meg. Over to you for your excellent presentation.
Thank you very much. Let me just pull up the presentation and we'll get started. So, we're very pleased to be here, and we're going to have a bit of a tag team and 7 minutes each to make our 15 minutes. And we'd really like to be able to share with you what we know about what's going on with both COVID and HIV from the WHO's perspective. Just Quickly, I'll be talking to the epidemiology, some of the associations, what we know about essential health services and guidance, and Rachel will pick up with prevention and testing and how we can build that better. As of yesterday, we have nearly 66 million confirmed cases in the world, 1.5 million deaths reported to WHO. And as you know, if you're following the news, that both Europe and the Americas have had a resurgence. We haven't yet seen a second wave yet in low and middle income countries, especially in Africa, but this is one thing that we're very worried about and preparing for as we move forward. Early in, and you've probably seen some of these slides in the past, we were concerned that the indirect effects by having interruptions of services, that they were modeled to show that we could have as many as 500,000 excess deaths in sub-Saharan Africa, an increase in new infections among children because of lack of attendance at EMTCT and PMTCT, and also some very concerning potentialities for new infections happening in children on that as well. So in many ways, we wanted to brace ourselves for the worst case scenario and really set up systems and approaches so we could avoid this. Then over time, there's been views around what are the direct effects. And I think we still don't have a final answer on this, but through a number of large population-based studies, both in South Africa, UK, and now out of New York, it looks like there's a moderate increased risk of death and severity among people living with HIV. Whether this is independent of low CD4 comorbidities, the most important thing is that people who are living with HIV, that they ensure that they have a suppressed viral load and that comorbidities are assessed and suppressed and cared for. And we've seen this now in multiple, both hospitalization studies where they're able to look at the breakdown between people living with HIV and people who are not, and we've seen this increased potential risk, as well as across systematic reviews. Early systematic reviews gave a view that there wasn't a little bit of a complex set of views because there didn't appear to be an increased risk. But as we add more data, this moderate risk appears to be increasing. So in many ways, it's important that WHO has a pulse on this, and we're working with many studies around the world to have a clinical database so that we can look at this directly. Early on, there was thinking that perhaps some of the lopinavir, ritonavir, and other antiviral medications could actually have an effect on COVID. As you can see from the Solidarity trial and many other trials, lopinavir, ritonavir provides no benefit. And PrEP for COVID, either using tenofovir FTC, TAF FTC, did not appear to also prevent acquisition of COVID. But what we do know is that with COVID, there has been some disruption of services. So from the beginning in June and July, we started to monitor and follow what were the potential impacts and what can be the mitigating effects. Here we see that many countries moved to implement their already well-known policies for multi-month prescription. And across all the WHO's regions, we see in dark blue that these countries were picking up the MMD at 3 months and some into 6 months, so that the medicines would be at the place when they needed them to use them. We also followed the stock availability and ARV disruptions from June until November. And what we can see in June, we had 24 countries reporting to WHO that they had ARV stocked of less than 3 months. And now we only have 12. So we're seeing some encouraging news that the original concerns of stock and stock disruptions, which were quite evident in June and July, seem to be recovering. As well as we've seen a 75% reductions in any ARV disruptions from 34 to 9 countries. So again, and this was across all regions, and certainly with the African region and the Eastern Mediterranean region being of concern. This next slide just puts it graphically, where red were the countries of concern early in June, And now we only have a few countries of concern for having major disruptions in their ARV supply. So that's the good news. We've also been following with UNAIDS, WHO, and UNICEF whether monthly we see any changes in the GAM reports. And what we see is that there has been disruptions in PMTCT, but over time this has started to recover, as well as some reductions in both testing, which you'll hear about later, but reductions in number of new people on therapy. So what we've seen is people who have been maintained on their previous regimen, that's gone well, but starting new therapy has been problematic in some cases. For World AIDS Day, WHO pulled together a number of different stories, and I think I would invite you just to go see these stories, because you've seen how the services have been very resilient in this time. And certainly for HIV, a lot of the HIV testing, the COVID testing, has been built upon the infrastructure of both HIV and TB. WHO in May and June put out a guidance around maintaining essential health services, and we're in the process of looking at updating this in the near future as things change. And certainly there's been a harmonized suite of health service capacity assessment modules, and these modules have been set out in countries to help them as they start to open up and reinitiate services that for a period of time during COVID might have been shut down. So I think we're seeing that recovery is starting to happen in many places, but as countries are bracing for the second wave, it's very important that the essential services don't go back to where we were in June and July, where we had major disruptions. And here, I'll just leave this slide up here and you can share this. But if you go to the WHO website, there are multiple resources available that can help in terms of preparing for opening up again and during and keeping all the services open. So with this, I'd like to pass over to my colleague, Rachel, who will take it from here. Thank you.
Thank you very much, Meg, and I'll talk a little bit about HIV prevention and testing services in the time of COVID. Next slide, please. It's now about 10 months since we really started thinking about this, and as COVID really started to affect countries, we were very, very worried about what this would do to prevention, testing, and contraception services. And so right at the beginning, we started to see that people thought condoms were no longer essential. We were worried about condom production. And we were worried with all the clinic closures that testing would diminish. So we we developed with UNAIDS a priority document to really provide the advocacy to tell countries that an emphasis on continuing services for prevention and testing was really important. Next slide. I'm going to talk about VMMC, voluntary medical male circumcision. This has been a really successful program across East and Southern Africa, reaching many millions of men and averting many millions of HIV infections. And of course, getting men into clinics and providing them with all the services for male circumcision was not something that could be continued during the early stage of COVID. So WHO recommended that services were temporarily paused. Next slide. And many services were, and of course that has meant that, and next slide please, and that certainly meant that medical male circumcision did decrease quite rapidly during the early stages of the first response to COVID, but has bounced back. And during that early stage, a lot of the staff and a lot of the equipment that was used for the male circumcision programs was diverted rightly and successfully to the COVID response. Next slide. During this this 10 months of COVID, though, WHO and all the partners working on male circumcision have really continued to think about what to do in the future. We had just we have just finished our guidelines. So during this period, we've released our guidelines. We've developed an app with our guidelines. We've disseminated through webinars. And as services are coming back up, we hope that these can be introduced safely and more effectively, particularly reaching the older adolescent group, really concentrating on the above 15s. Next slide. I now turn to PrEP. Next slide. If there's been a lot published, and I've just picked out a few studies here from around the world looking at what's happened to PrEP services, and probably not surprisingly, these have been effective. Many more people haven't picked up prescriptions or returned to clinics just because clinics have been closed or more difficult to get to. And this is particularly for the MSM services, for which there are most information. But also one study here from South Africa showed that this was the case for PrEP amongst pregnant and postpartum women. The MSM studies also report, but possibly this is because there were less men requiring PrEP during these early phases where there was decreased ability to meet people. And certainly reports now are of increasing PrEP demand back to the the pre-early stages is starting to happen. Next slide. And we've learned a lot about how to deliver PrEP in a more efficient and a more people-centered way during COVID. Thinking about providing information online, providing home pickup of PrEP refills and of HIV self-testing, which can be done in between times to check on the effectiveness of PrEP. Next slide. And a lot has happened in the scientific world during these months of COVID. Really extraordinarily, things have continued with the trials, for example, on the long-acting products. And very excitingly, only a few weeks ago, the results from the long-acting cabotegravir trial in women, which was carried out in multiple sites in southern and eastern Africa, showed this to be highly effective. And those trials were continued. And we have this wonderful result to add to that of the MSM effectiveness, which was earlier in the year. And also the dapivirine ring, which offers an additional prevention choice for women, has been approved through the EMA Article 58 process and is now on the pre-qual list. So a lot of exciting prevention developments have happened despite COVID, and WHO will work on these over the coming months to see how the next steps for their introduction. Next slide. Key populations, I think across the board, and on the graph here is showing access to services for men who have sex with men. There's a large report that UNAIDS have done on services across key populations, all showing real stress on these services during COVID. Next slide. WHO, again, working with partners, has really tried to support continuation of services and like for treatment services to increase more community-based distribution, longer delivery of things like OST and needle syringe programs. And as we move through the next year, WHO is continuing to work on updating its guidelines, and there's a big process that's already started with community consultations and involvement of the community networks. Next slide. And finally, testing. Again, as Meg said, we all anticipated that because so much testing is done in facilities and people were less likely to go to facilities and facilities were open less services, that testing would be a major casualty of the COVID response. And so we started to provide guidance on how we could maintain testing services during COVID. Next slide. And one of and so then just looking at some data here, as Meg showed previously, really quite some significant declines in testing. Greatest decline was not in amongst women in antenatal clinic, because these services have been largely maintained, but a significant decline in men, non-pregnant women and key populations. Big differences in countries, and overall with this decline there has been a similar positivity rate that was seen before COVID, which means that there's an absolute drop in the number of new HIV diagnoses that have been made over the past 6 to 9 months, which means we will really have to think about catch up. Self-testing has really come onto its own in this COVID time, offering a safe, convenient and empowering way to move forward for knowing your status outside clinical settings. Next slide. And there are numerous examples across the world, and I've just today been looking at the Asia region, and it's really heartening to see how many countries in Asia are now embracing self-testing and thinking that COVID is a time when we should really fast track this to support access to testing for people. And finally, looking at the COVID response and seeing how HIV can be integrated into this. So in high burden HIV settings, if a lot of COVID testing is happening, particularly in the community settings, can also information about HIV be incorporated? Can self-testing kits be given? Can condoms and other commodities be part of the distribution? And certainly South Africa has embraced this. And I think COVID really has changed the way that we've thought about working with communities and working outside health settings. We've learned a lot, and a lot of these lessons will continue in the post-COVID era. Next slide. So what we really have to think of is building back better, is one of the WHO slogans. Building back better for prevention, looking at more decentralized ways to deliver services, and Meg's, sorry, I know we're very short of time, so I'll be very quick. Looking at self-testing, particularly looking at self-testing for other infections like hepatitis C, supporting multi-month scripting. We've done fantastically well. We need to do even better, really supporting that for everybody who could benefit, not just for ARVs, but for other, for OST, etc. Lots more use of the virtual space for case management, and really looking at self-care. And there are a lot of people on this thank you slide, and it's because I think in WHO, like elsewhere, our lives have been, turned upside down by COVID. So all of us, although we continue to be passionate about working on HIV, we've all recognized the need to adapt to COVID and learn from COVID. Thank you.
Fantastic. Thank you so much, Meg and Rachel. There was a lot in there, and we've had a couple of questions coming in to the Q&A box. Can I remind everyone to please post those questions in the Q&A box, not the chat box, so that's where we'll look for the discussion at the end. Some really interesting points there, both around some of the differences seen between countries and also between population groups, pregnant women or different key population groups, and some of the opportunities as well that Rachel concluded with to connect different either COVID-19, HIV and other services to best respond and build back better once the new normal settles down. So a lot in there. Thank you so much for a terrific presentation, and I look forward to coming back to you both in the panel discussion at the end. I'd like now to introduce Professor Adiba Kamarulzaman, who's going to present on lessons learned regarding policy and pandemic preparedness for people living with HIV in Malaysia and also across the region in Southeast Asia. Professor Adiba Kamarulzaman is the President of the International AIDS Society and the Executive Director of the Centre of Excellence for Research in AIDS, CERIA, at the University of Malaya, which Adiba established in 2008. She has a very impressive CV and a long line of accolades in the response to HIV. But just to highlight a few, Adiba was president of the Malaysian AIDS Council from 2006 to 2010 and continues to serve as an executive committee member since stepping down as president. She's also been involved in advocating for and overseeing the implementation of community-based HIV programs across the country and remains a chairperson of the Malaysian AIDS Foundation, a trust whose role is to raise funds for HIV prevention, treatment and care programs across the country. Thanks very much for joining us today, Adiba. The floor is yours.
Thank you very much, Lucy, and thank you, Meg and Rachel, for that excellent and comprehensive overview of the response that has taken all around the world for the HIV programs in relation to COVID. What I'm going to do in the next 10 minutes is really just give you some examples of the responses that have taken place here in Malaysia and also in Thailand. And for that, I'd like to thank Dr. Nitya Panupak, who's also a member of the IAS's Governing Council, for sharing his slides with me and for the excellent work that Nitya and her team in Bangkok, Thailand have been doing throughout this COVID pandemic. As you've heard from both Meg and Rachel, there are many challenges in relation to COVID that have led to disruption of HIV, both prevention and treatment programs. And these are just some of the individual level challenges that have been faced by people living with HIV or those at risk of HIV. And we know that one of the reasons why members of the public, including those living with HIV, do not come forward for care is because of fear of contracting COVID-19 itself. And then, of course, you've got government guidelines and lockdowns and physical distancing guidelines that result in just inability to come to clinics. On top of that, as you know, COVID-19 is not just a health catastrophe, but it's also been an economic catastrophe for many individuals and nations, and that financial stress and loss of livelihoods have also contributed to mental health and substance use. And all of this have affected individuals, members of the key population, but one group that I think, at least in the context of Malaysia and Singapore, where we've seen large outbreaks amongst migrant workers, is probably amplified, and the level of vulnerability amongst the migrant workers is certainly at another level. Migrant workers and prisoners, you've got layers upon layers of vulnerability, but for undocumented migrants who don't even have access to healthcare in the best of times, COVID-19 has presented unprecedented challenge. At the country level, you've got strained national healthcare systems, and this is happening not just in lower and middle income countries, but you can see that happening in the US and even in wealthy nations where healthcare systems have been overwhelmed due to just the sheer number of cases and patients. And the shift has really been from from diseases to virtually focusing on COVID-19 alone. Because of diversion of staff to care for COVID-19 patients, obviously there are shortages, and on top of that, this we experience quite frequently when you have either staff themselves or ourselves falling ill from COVID-19 or having to quarantine because of potential exposure to COVID-19, and that leads to previously a 14-day quarantine, but I know that CDC has shortened their quarantine to 5 days. That has from time to time led to staff shortages, whether it's in the ER or in ICU or in OT, amongst nurses and doctors, that can further complicate the provision of services. All these and other reasons for leading to challenges in the healthcare, then what we see are delays in linkage to care, and specifically for people living with HIV, diagnosis of opportunistic infections, and potential treatment failure. And last but not least, and I think this is a long-term concern, that many HIV programs, particularly in Malaysia, where a lot of our funding is domestic funding, there is already growing concern that there'll be funding diversion from HIV and other related programs to fund ongoing COVID-19 mitigations. So you've seen some examples of disruptions that have occurred around the world that Meg and Rachel shared with you. This was a survey that was carried out by Gilead Asia Pacific. It was a phone survey to HIV service providers and prescribers and people living with HIV. And in short, 50% of prescribers experienced disruption of HIV care during COVID-19. This is in countries in Southeast Asia, in terms of frequency of visit and patient load. And a similar disruption in frequency of visit was also reported by at-risk population, at-risk people, half of them, and to some extent people living with HIV reported 35% of service disruption. What about access to HIV testing? So both persons living with HIV and the at-risk population reported a decrease in access to testing, predominantly due to concern of getting infected by COVID-19, with COVID-19, and also travel constraints. So 47% of at-risk population reported a decrease in their HIV test frequency, and out of 5 of PLHIV stated that test frequency had decreased during COVID-19. What about preventive care? So what was found in this survey was that this was heavily impacted during COVID-19, where 60% of prescribers reported a decrease in preventive prescriptions, PrEP, for at-risk population. Once again, due to travel constraint and also people's modified risky or unsafe practices. And over 40% of people at risk reported a disruption of their PrEP medication, either decrease or stop completely. So this is an example. So that was an online survey. The following slides that were shared with me by Dr. Nitya are the real examples of the services that were affected in Thailand, and also the innovations and the innovative responses that were taken up by our colleagues in Thailand in order to overcome some of those challenges. So they did see a drop in the number of new HIV diagnoses and ART initiation. And people living with HIV were not able to travel to obtain ART from their usual providers, especially those who had left the cities and migrated back into rural areas or provinces following the COVID-19 outbreak. And some major centers saw a huge decline in the number of HIV and STI testing, up to 50 to 75%. And in the beginning, the supply of PrEP was also uncertain. So what were the adaptations that our Thai colleagues did? I guess multi-month dispensing was one of the first, and you've heard this taking place all over the world. And in Thailand, this was endorsed by societies as well as ministries, and procurement and stock management were done at national and local hospital levels. Telehealth came to the fore, as you've heard also from WHO, and mailing of their antiretroviral medications. This also, both multi-month dispensing and telehealth and mailing of medications were also adaptations that we undertook here in Malaysia as well. Flexibility of antiretroviral service outside of registered hospitals, and so this sort of decentralization of services occurred in Thailand. And what has not taken place in Thailand was HIV self-testing. Likewise, in Malaysia, we are in the final stages of online HIV self-testing program that hopefully will roll out soon and expand the services, COVID or no COVID. What about prevention services? Thailand, as you know, have had an outstanding program that's key population led. One of them is the Thai Princess PrEP program. They have a defined set of HIV-related health services that focus on specific key populations, usually identified by the community itself, and are therefore needs-based, demand-driven, and client-centered, and trained and delivered by trained and qualified lay providers. So this program, even before the COVID pandemic, was already in place. And in response to the need to scale up PrEP in Thailand. And as you can see here, the blue or the turquoise bar or graph corresponds to the Princess PrEP program that's delivered by lay providers. As you can see, they are the largest provider of PrEP in Thailand, and certainly plays a major role in the scale up of PrEP in Thailand, and continued to do so during the COVID pandemic. In addition to providing direct HIV services, whether it's prevention or treatment, these community-based services were also instrumental in ensuring that other needs such as food packages and other daily necessities, and also housing and shelter were taken care of, and they also developed toolkits for those for sex workers during this pandemic. So as you can see, with the existence of a mature key population-led program, it was not. The response to COVID came, I guess, pretty naturally. As you can see here, with PrEP screening, what they do is in the continuation phase, instead of every 3 months, with the COVID disruptions, this was extended to every 6 months in terms of the service frequency. The KP-led clinics remained, but also augmented by telehealth mode of service delivery. And whether it's in the initiation phase or in the continuation phase, this service was provided by key population-led lay providers. And in terms of other services, in addition to HIV and syphilis same-day testing, in the COVID period, all these were delivered in an express form or self-sampling and testing, particularly for STIs, and PrEP will continue to be delivered through this modality. what about for people who use drugs? I'm going to use an example from here in Malaysia. So during, at the beginning of what we here in Malaysia call the Movement Control Order, the partner organizations of the Malaysian AIDS Council and the Malaysian AIDS Council went into action to ensure that clean needles and syringes delivery were not disrupted. So they extended the distribution of the needles and syringes, which normally are given 2 or 3 times a week. So the partner organizations extended and gave out more clean needles and less frequently to the clients that they were serving. Alternatively, the clients were able to come to the organizations to pick up their packages. And in terms of returns, there was a drop in return rates, which are normally what we call MCO, was as high as 75% to 30% in the early days. There were concerns about potential shortages of needles and syringes. However, reportedly, there have been no major shortages of needles and syringes throughout this period. So before this was just a quick interview with some of the clients, of whom 77 out of the 293 we use drugs. Before the MCO, this cohort of people, 66% were accessing the needle syringe program. It dropped to 40% during MCO. And the largest drop was seen in those who go to pharmacies to receive their clean needles. But there was not a major drop in those who get their supplies at drop-in centers or with outreach workers. And the vast majority agreed that they didn't have major disruptions in their needles and syringe. Challenges that they faced was because there were roadblocks to ensure that people stayed at home. This created naturally fear for people who use drugs, the fear of interaction with police, because drug use is criminalized here in Malaysia, and hence the fear to come forward to receive these important commodities. What about opiate agonist therapy? The major change there was in terms of the ability to take home methadone. The Malaysian methadone maintenance treatment were very reluctant before the MCO to allow long-term or long duration take-home messages for methadone, but because of the MCO leading to this necessity to prolong the clinic visits, the Malaysian Ministry of Health then, I guess, relaxed the rules, and people who were receiving methadone were able to take home, provided they're stable on methadone for a much longer period. So those are just some of the examples of the adaptations that took place in both Thailand and Malaysia for programs that were focused on key populations, including MSM, transgender, sex workers, in relation to ensuring that these prevention and treatment programs continued, and as well in Malaysia, ensuring that harm reduction programs continued without major disruptions. And I think, as you heard from both Meg and Rachel as well, I think what the COVID pandemic has really taught us and shown us is the importance of community-based programs, the adaptability, the dedication, commitment from community service providers to ensure that these important prevention and treatment programs continued. I think moving forward, building back better, as the WHO slogan is, we really need to look at how community-led programs must be institutionalized and made part of the greater public health program. Not only community-led programs provided there's adequate training and funding. I mean, they should be integral to a good public health program, particularly for those that serve, the marginalized communities where, these individuals are rather reluctant to go to traditional medical institutions. So with that, thank you very much for having me this evening, and I pass it back to Lucy.
Thank you so much, Adiba and Nataya. Obviously, there's some fantastic details in there from both Thailand and Malaysia, and I look forward to coming back to those at the end. Just to let everyone know, we are going to continue. We have another presentation to conclude, and we do have a few minutes for question and answer at the end, so please do stay with us. I'd now really like to hand the floor to Dr. Eleni Kutu, who is the Director of STI and HIV/AIDS Programs with the Mozambican Ministry of Health. Dr. Kutu is a musician, is a Mozambican physician with over 6 years of experience in the public health field. Prior to joining in her current role, before 2011, she was a clinician in the local hospital assisting people living with HIV in daycare at the hospital, and has more than 10 years of experience working in HIV in resource limited settings. Thank you so much for joining us today, Dr. Kutu. The floor is yours.
Thank you. Please let me share my presentation. Good afternoon, everyone. Thank you, EIS, for this opportunity to share with this in this platform what was the Mozambique experience related to HIV and COVID-19. My name is Eleni Couto, as it was said, and I'm the head of STI and HIV program in Mozambique. As introduction, we see the prevalence of HIV in Mozambique is the 13.2%, and by 2019, through Spectrum was able to estimate that we have 2.2 million people living with HIV, and we have new infections, 130,000 new infections and 51,000 deaths related to HIV. In terms of transmission, mother to children is 14. And in terms of cascade, we're still saying that we are far behind. On the first 90, only 70% of our population know their serostatus status. Only 58% are on ART, and only 44% on viral suppression. When it comes to COVID-19, till the data from yesterday, we already tested almost 240,000 people. For those tested, 16,000 were tested positive, and only 1,691 still active to COVID-19 till the moment, and we had 133 deaths. So when we had the first case of COVID in March, what we did, what was the measure? We had a lot of measures. That was a more partial lockdown in country, but since that we had the emergency call in April, but from September we had the calamity state declared by the president, where we said that there was the mandatory face masks must be used. We have to social distance of 1.5 meters. We open our borders, but COVID-19 test result is mandatory to enter the country. It has to be negative to enter the country. Universities and schools were opening in a phased approach, and also public spaces, sports, religious service, and celebrations were allowed, but with several restrictions in number of people. So what was done? We had the first case. We had to think very quickly. What we did was to change the patient flow. We have to issue circulars. Where the circulars, we have to really think what we can be kept in terms of continuity of service, what has to be cut, since we are at that time in March, we didn't know much about COVID. So, but what we did in terms of circular, it was we have to keep what was important for us. But at community, most of the activities at community were cut down, mainly in terms of PrEP, in terms of HTC, all of this. In terms of the visits at home, they will cut in March of 2020. We cut all these activities at community level, but we kept the HTC, the PrEP we kept this at the health facility. In terms of patient flow, what we did were to really make some change at reception, where we can give some information in terms of COVID-19. We had in waiting room information about COVID-19, but at the clinical consultation room, what we did was the psychosocial support, nutritional screening, TB and OI screenings, all of this. We have to measure blood pressure. We have to screen for diabetes mellitus, but also what we did was a one-stop shop there where we can offer ARVs and some of prophylaxis dispensing. All of it has to be done at the clinical consultation, because we used to have clinical consultation, then go to pharmacy to pick up the drugs. But what we have to change when health conditions, we have to offer all the service, all the dispensing inside of clinical consultation. But after 3 months, that was in March, after 3 months in June, July, we had to measure the impact of COVID in our indicators. What we did by the end of August, we decided that we have to go back to do all the activities, so we cannot really have some disruption in country in terms of indicators. So what we said that we're going back, but we have to reinforce the measures in terms of using the mask and reinforce all the prevention, using the mask, social distance, and washing the hands with water and soap, or using of alcohol gel. But also we have to really inform our patients, because our patients were scared to going to the health facilities. They were scared of getting COVID inside of the health facility, but we had to really inform them that it's possible. They have to continue to do the service, and we had to do a lot of EAC materials so we can inform radio spots, so we can inform that they have to go back to the health facility in order to continue to do the treatment. In terms of results, what were the impact of COVID in the indicators, the main indicators of the program? When it comes to testing, as you said, this was shown by the previous colleague from WHO. We were in March, we reached a certain point, but when we declare emergency state by the end of March, we saw it in April that we have that decline of our number of people tested. Then in June, July, we saw all this decline. What we did was saying that we have to go back mainly to test at community, because most of this testing were kept inside of a health facility. And now we saw that in August, by the end of August, again, we saw some increase of testing in country. But in September, by the end of August, September, we declare our calamity states. Also, we saw some declining, but now we are seeing again the increase. So we can see here some oscillation of the people tested during this month. But we can see the main drop was in April. In terms of monthly consultations, we also saw that people didn't go to the health facilities. They were, as I said, they were scared to go into the health facility. So we saw some drop of the monthly consultations, and we kept seeing all those drop till the end of June. And we have to really do a lot of information, spread all of the spots, radio spot, TV spots, and also posters to the health facilities in the community in order to increase again the number of people going to the health facility. We saw some increase, not the way we wished, but also this can be affected because we really relax in the terms of criteria of the multi-month dispensing, and we saw the increase of the people taking 3 months drugs, which as I'm going to show in the further moment. And we also had this dashboard to measure the defaulters and loss of follow-up patients. We saw that we saw an increase of number of follow-up patients in April. So we said that 11.4% of our patients were defaulting the consultation. By the end, then we saw some drop. we increased again, but we went back to what was our number in January. We say that 9.3% of our patients were defaulting in January. We didn't have COVID-19. Now we are seeing that 8% of our patients are defaulting the COVID. But the main peak, we saw it that in April. In terms of new people initiating on ART, on ART, also we saw that there was a drop of people. We are not testing, we're not diagnosing new people, so we saw the drop of the people of initiating ART in countries. So we've seen from April till July, the drop was there, but again we saw some increase in August. In terms of patient coverage, HIV coverage, we saw a slightly increase, but this is mainly because we saw many of our patients coming back so they can pick up for the 3 months drug distribution. In terms of viral load performance, those ones we went to the health facility and were possible to collect the viral load. As you see, in April also, we saw the drop of patients that were not collecting were not performing viral load. Again, in August, we saw some increase, and then from there, we are seeing some oscillation. For those one who went to the health facility and collected viral load, the viral suppression was 63% lastly in the month of October. In May, we saw the drop, but those ones who collected, we saw that the viral load suppression was 84%. Now we're seeing that some increase in August, but the viral load suppression for those ones who collected viral loads at that time were low than those ones who collected in April. We can see some variation here in terms of viral load suppression. We collected more blood samples for viral load in August, but we see less of these patients with the viral load suppression. In terms of DSDs, here we are measuring 2 of them, differentiated service delivered, like community adherence support groups and 3 multi-month drug dispensation. We saw that when we declared the emergency state in April, 43.5% was the number of eligible people that were in 3 months drug distribution. When we started the emergency state, we had to make some changes in the health facility. We have to dispensing at clinical consultation, but also we have to relax our criteria in terms of multi-month drug dispensing. Because of this relaxation, we saw that the increase of number of people, the coverage of people were in 3 months drug distribution from 43.5% to 67% from April to October. So we can see that most of our patients, they were able to have some 3 months benefit from 3 months drug distribution, and some of them were 6 months drug distribution because we're just doing this at Maputo City and Gaza province. In terms of community adherence support groups, we didn't see much change. We just changed from 8.7% to 9.11%. So when we issued the circular, we had to maintain our service, but we had to maintain this service by reinforcing the prevention for COVID-19. We had to reduce the frequency of visits at the health facility. For those ones who went to the health facility, we had to reduce the time of waiting within health facility. But all of these measures were taken in order to implement the policies and taking the account of context of COVID-19. And based on that, we see the results. There was some disruption, but also we had to really make so many information in terms of how they can protect themselves but not acquire COVID-19. And also we have to go back to our activities at community when it comes to PrEP, when it comes to testing, when it comes to also at the health facility, when it comes to PMTCT. We really had to rethink about how to do all these things. At the beginning, you used to have 3 months drug distribution for those ones who are pregnant and lactant women. But with our colleagues or MCH, they said there are some problems with some pregnant women. Now we went back to 1 month drug distribution, but for lactant women, we're still having distribution for 3 months drug distribution. So what are the key recommendations based on all this that I've already presented? The first recommendation, we really have to monitor very, 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 very well. So calls with the provincial teams, following the formal communication, it will help implement the guidelines correctly. So when you issue a circular, you have to really make sure that you have to follow. You're not able to go to the field at that moment. We were not able this time. This year was very atypical. We didn't go to the field, but we have to really monitor virtually what is happening at the health facility and monitor our data. So monthly calls are done to discuss all the new recommendations. We saw that most of the people sometimes we didn't comprehend what we are saying. So we had to really work with them and explain of them, even though we had the very, very misinterpretations of our circulars. Also, the communication with the recipient of care is very key. We have to really issue videos, radio spots. If you have group of WhatsApp, we have to work with them through those groups of WhatsApp, Facebook, meeting with community leaders. All these people at community is important that you have to sit and discuss with them how they can be involved, how they can really cooperate with us in order to not have disruption. And mainly when we have community activities that have been done that were stopped, then we have to really go back to those activities. Lastly, what is important to do all this activity, knowing that you in the era of everything that is virtual, is that data is very important to guide implementation. All the dashboards, all the electronic platforms that we use to measure the photo patients, how many patients were and 3 months drug distribution, how many patients were collecting viral loads, how many patients are entering on the ART programs. All these were really measured very, 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 very monthly and very, very, very close. We had to really do this very close, and we used to do this monthly calls to discuss HIV program data, and this is will also been done with the provincial level. And thank you very much. Over.
Muito obrigada, Dr. Couto. Some fantastic learnings there from your experience and leadership in Mozambique there. And particularly, I think what you were just saying at the end around data and really monitoring these complexities in a real-time way almost, and using that data with monthly calls, I think you mentioned, with different key actors at the different levels. And I think fantastic examples built into your presentation about responding to the changing times this year and trying to mitigate the impact. So thanks very much for joining us, and thanks for those insights. We're almost out of time. I just have 1 or 2 questions for each, and we just encourage everyone to please continue posting the questions in the Q&A. Some of those, or many of those, have been responded to real time by the panelists, or please do send them after the close of this webinar to coronaquestions@iasociety.org. We'll put that email address in the chat as well, and we can help filter those questions back to the speakers for a response after this webinar today. But I wanted to come back to 2 specifically for WHO colleagues. But Rachel, there was a question, and sorry, Meg, there was a question and you did answer it, but I think a few people have indicated it's popular, so it might be worth answering it publicly here about outcomes for people living with HIV, with TB and or with COVID-19, and what the data is telling us on that. And then for Rachel, some specific questions really in relation to HIV self-testing, and in a country where that isn't available, how can someone go about starting that up or advocating for that to start up? And also a question around any considerations for emotional or mental health well-being, or some of the counselling aspects to go alongside HIV self-testing. So if I can give the last word to the 2 of you on those different points from WHO perspective, just before we close the session today. Thank you.
So why don't I start? Thank you very much, and we'll start. I answered the question. I think there's a lot of different data out there right now, many different studies, probably in the 50s or 60s, looking at the association between HIV and COVID, as well as other diseases, including tuberculosis. For low and middle income countries, one of the most complete data sets is from South Africa, where Andrew Boole and Anne-Marie and Davies presented already in July around data that showed the highest risks to be related to death to COVID were related to NCDs that were untreated, but there was also some element of risk in the 2% range for HIV and as well tuberculosis. I think those data are being interrogated again, and we've seen some other data coming out from other countries that have shown some elevated risk with HIV, and in New York, perhaps among people who have other comorbidities or a low CD4 count. I have to say, you know, we need to get better data. And when we looked at some of the systematic reviews, the early systematic reviews did not show an association, but the later data are starting to show some association. So the important thing is stay on antiretrovirals, have a good viral suppression, and ensure that all clients and others really maintain low risks in the comorbidities such as NCDs, end-stage renal disease, hypertension, diabetes. For tuberculosis, I think also the data may be, you know, there was a concern that certainly if you had lung disease, that would put you at greater risk, and they've seen chronic pulmonary disease as being associated with COVID. The TB association is somewhat like HIV. We need more data. And certainly there's some indications in some ecological studies where they've seen the thought, you know, a hypothesis is perhaps that the BCG vaccine has been somewhat protective. Really hard to know, because I think the places where BCG is most prevalent has not had a really huge impact of COVID. And you heard from Eleni how well they've been able to keep COVID at bay. And so I think it's really impressive what's happening there. So I think we'll only know most about all of this as data become more available, but certainly the NCD risks outweigh the HIV and the TB risks. So please make sure that NCDs are well controlled as well as you think about these issues. And we know people suffer from HIV, TB, and NCDs. They can travel together, so important to have all of that well controlled clinically. Thank you.
Great, thank you, Meg. Rachel?
Oh, well, thank you very much for the interest in self-testing. As you know, we in WHO are very excited about the potential of self-testing, and you know, I think it has come into its own as a safe way to access testing during COVID, and an empowering way. And so for countries that haven't yet adopted self-testing, it's really time to engage with the ministry to see which if they can start the regulatory process. It can be quite simple. WHO has already pre-qualified 4 self-test kits. The prices are very reasonable and can be included in PEPFAR or Global Fund proposals. And the more volumes we get, the more potential we have for reducing those prices even further. You know, WHO has guidelines and lots of material to support implementation. So if your country isn't looking at self-testing, I suggest, you know, nudge them. Do get in contact with the WHO or UNAIDS colleagues in countries, or directly with us, and we can link you up. In the chat, there's and one of my slides I talked about some of the work that PATH's doing. They've done some really fantastic work in Ukraine and across Asia on self-testing, and particularly with key populations. And I think there is increasing evidence that for key populations and for men, through workplace testing, ILO has done work on this, on offering self-testing in workplaces. It's really offering an opportunity for people to learn their status. And, you know, despite all our concerns, you know, we've worried for 20, 30 more than years about people, you know, reacting badly to a positive result. But nowadays, life's good. If you have an HIV positive test, you can get on treatment and you're going to be absolutely fine. And you're not going to be able to transmit HIV to partners. So it's so much better to know. And I think we have to get those messages out to communities and working with communities. So again, in Afghanistan, which was the country was particularly asking, talk to talk to your groups, see if there's any questions that they still have unanswered, and link them up to others who are working on this, and we can put you in touch with groups that and I'm sure many of the organizations that are doing this would be really happy to have virtual learnings with you.
Fantastic. Thank you so much, Rachel. And thanks to all the panelists, Eleni, Adiba, Rachel and Meg. What a fantastic session. We could go on talking about this, I'm sure, for a lot longer, but really appreciate the specificities actually and the details shared, as well as some of the broader recommendations and implications for other settings as well. So thank you so much for your time. That's bringing us to the end of today's webinar. Please know that the slides and the recording from today's session will be available on the IAS website. And that address is just going up on the slides now. And please do continue to send questions as they come to you, or specifically for any individual speakers to coronaquestions@iasociety.org, and we'll make sure they get shared with the speakers. We'd also particularly like to thank the Swiss Agency for Development and Cooperation, SDC, and Merck Sharp & Dom, our sponsors for this. Without their support, this webinar and the series wouldn't have been possible. And we'd also like to ask everyone to please take a moment to complete a short evaluation survey that will pop up on your screen just as we conclude just now. Your feedback is really helpful for us, including thinking about important issues for future sessions such as this. So thanks very much in advance for taking a minute to complete that survey. And thanks very much for joining us today. That brings us to the end of the session today and the end of the series for 2020. Please do continue to stay in touch with the IAS via the COVID-19 and HIV platform, and wishing everyone a lovely afternoon, evening, day. Bye-bye.